Good morning, everybody. Welcome this morning to a very special event, Grand Rounds, our first Grand Rounds, named for a really wonderful person, Ellen Susie Bromberg Skolnick, and various combinations of names in there that we all know her by. This is a very big picture of a small woman with an incredibly big heart who passed away recently. And we're very fortunate to have her family here today who have named this lectureship in her name. She was an incredible woman who, shortly after the birth of her daughter, Rebecca, who is here today, developed scleroderma and developed many of the complications arising from that. And despite all of the things that she went through, she didn't let her disease define her. She defined way beyond any of the expectations. She defined herself. She was wonderful in that she went above and beyond to educate people of all walks of life, med students, doctors, and lay people, about the impact of kidney disease on the patient and on their families. And she, most importantly, from my perspective, with regards to today's lecture, educated up-and-coming physicians about what it is like to be a person with an illness, and not defined as a patient, but a person with an illness, how that impacts their living, and how we as physicians can impact that person by demonstrating kindness and thoughtfulness towards that individual, and help them through that incredibly stressful journey, and how very simply we can lighten their burden by being kind and considering their whole being and not just their illness. Very importantly, she also demonstrated to med students and residents how very easily, through small actions and inappropriate words, we can dehumanize a patient and have them feel small and humiliated, and how that ultimately impacts their outcome and in the end doesn't help them. And she did a wonderful job of explaining this to med students. And she worked with many of us to come in and teach. Many of the physicians that took care of her are here today. It was a privilege and an honor to be part of her life and to be her friend. And today, the awardee, I cannot think of a better person to receive the award today, Dr. Coyle, an incredibly kind human being. He brings kindness and humility to everything that he does. A wonderful educator, which Ellen would love. And very importantly, somebody who takes care of people that otherwise wouldn't be taken care of. And so with that, I'm going to hand over to Dr. Katz to introduce our speaker today.
Thank you very much. As Dr. Murphy just mentioned, we have a very special Grand Rounds today. I'm greatly honored to introduce the inaugural recipient of the Ellen Susan Bromberg Skolnick Lectureship in Humanism, to someone I consider personally to be a mentor and a friend, Dr. Andrew Coyle. Dr. Coyle received his medical doctorate at Case Western Reserve University. He then went on to complete his training in internal medicine as well as a chief residency year here at Mount Sinai. Dr. Coyle currently serves as an assistant professor of medicine and is the associate program director for ambulatory care for our residency program here at Sinai. I first met Andy when I interviewed here for residency. He was at that time a chief resident who happened to be at the night social event. At that time, I thought to myself, if the residents at this place are anything close to this guy, this is where I want to be for my training. Little did I know he would become a close friend and a mentor, as he has for countless physicians in training. As a physician who truly dedicates himself to the mentorship and education of other aspiring physicians, and as a humanitarian who has dedicated his clinical time to serve the underserved populations of our community, I could not think of anyone more suited to give this inaugural lecture. Dr. Coyle truly embodies the kind of physician that Ellen Susan would have enjoyed working with. Please join me in giving a warm welcome to Dr. Andrew Coyle our inaugural Ellen Susan Bromberg Skolnick Lecturer.
Put this on the floor so I don't break it. So thank you so much for the introduction. I hope I can live up to some of those really kind and meaningful words. And I think more importantly, hopefully I can live up to some of the ideals espoused by Ellen, someone who I obviously didn't have the good fortune to meet, but someone I've sort of loved hearing about. And it's been wonderful meeting family today, and I think really a testament to her, but so many of her family and former physicians are here today. And so I have no financial disclosure, obviously. And so I think the frame through which to sort of think about what I want to talk about today is sort of humanism in medicine. And I think it's a sort of thing that is important to define sort of up front. And there's a sort of wonder article from Academic Medicine several years ago where they surveyed a bunch of residents at Penn to think about who were the most humanistic physicians in their sort of hospital, and then sort of interviewed all of those most humanistic physicians to figure out sort of what made them tick, what made them different. So one, they provide a sort of definition for us for humanism, combines scientific knowledge and skills with respectful, compassionate care that is sensitive to the values, autonomy, and cultural backgrounds of patients and their families. They also gave us sort of a list of attitudes and traits that sort of came up time and time again in these physicians who were thought to be the most humanistic practitioners in the hospital. So they exhibited humility and curiosity when it came to their patients. They viewed their humanistic traits not only as important to the patient, but important to themselves as providers. They saw their role as being beyond just treating the disease and treating the whole person and getting to know their patients and forging real and meaningful connections. And they took very seriously the duty to teach and role model humanism. And so I'll come back to all of this at the end. And I think, the title of this talk that I gave is sort of moving from data to action when it comes to homeless health. And so I think that's not only sort of the topic we're talking about, but I think it's also sort of a mantra for us about moving from just sort of collecting data and making observations about disparities to actually doing something about populations in need, and then really thinking about patients in those populations as specific individuals to really address their care. So a few things to mention up front. So one is I feel like I just gave grand rounds on medical care of homeless persons. And as I was looking through the slides, I realized it was a long time ago, actually. So this was a gratuitous picture of my daughter I ended with. And this is her now. So things have, there's more gratuitous pictures coming. So things have changed, and the question is in sort of like the last 3 years, what, if anything, have we learned about sort of caring for homeless individuals? And so two caveats up front to sort of give. One is that because I am at Mount Sinai and I have access to our data, I will talk a lot about the ways that we haven't performed as well in caring for this sort of challenging population. That is certainly not to say that we are doing worse than other places. In fact, I think we do better in caring for this population. I really and truly believe that there's a culture that comes from institution down about the value of caring for vulnerable populations and being engaged in our community. And I think there's values that come up from the medical school in terms of really sort of tackling health disparities. So this is not to say that Sinai is worse than other places. I actually think we're better at this in most places. The second is a lot of stuff is happening all around the health system, and I'll try to present that health system level work, but certainly that's not me trying to take credit for others' work. And at the end, I'll give very specific acknowledgments for people who've been instrumental in moving some of these projects forward. So in terms of sort of what I'll try to talk about today is a very brief refresher on sort of homelessness in New York, what the sort of situation looks like around us, the care persons who are homeless receive at Mount Sinai, and then what that data tells us. So what we can learn about these patients, what it tells us in terms of hospital and health system interventions, and then perhaps most importantly for this group, what that tells us in terms of what we as providers caring for individual patients can do to improve their care and make their lives better. So thinking about sort of nationally, this is looking at the number of homeless persons. There are about 500,000 homeless people in the United States on any given night, with New York having the second largest population at around sort of 90,000. So California is the only state with more homeless individuals than New York. One sort of notable feature, though, is in New York State, about 85% of people who are homeless reside in New York City. And so New York City has the largest homeless population in the country by a pretty wide margin, LA being second, and sort of all other cities being significantly smaller. So an enormous homeless population in New York that we need to sort of try to figure out how to provide optimal care for. sometimes it doesn't seem like that sort of much of a problem, and that's sort of a really nice thing about New York State, is that New York State has a constitutional guarantee to shelter, and so the city is obliged to provide shelter beds to anyone who wants them. And so 63,000 people are in the shelter system on any given night, so this is sort of one night in February. And I think what is notable about the number of people in the shelter is some proportion, around 18,000, are sort of like the stereotyped version we think about homeless individuals, single adults, typically male, but huge number of families, huge number of children in the shelter system in New York. When we think about these shelters, 400 in total, spread all around the city. There's a number near our hospital. So each of these stars represents a homeless shelter near us. We're obviously right here, it says Mount Sinai Hospital. And so all around us in East Harlem and Harlem are a huge number of homeless shelters. And as we look around the health system, the same pattern holds true. So St. Luke's, a huge number of shelters in Harlem near St. Luke's. Mount Sinai West, huge numbers of shelters surrounding the hospital. Mount Sinai BI, most especially, a huge number of shelters. So this is sort of the Bowery, the historical center of homeless shelters and homeless care services. This is Tompkins Square Park, a typical sort of epicenter for street homelessness. The last sort of New York specific thing before I start being sort of more granular about Mount Sinai is street homelessness. So mercifully, only about 5% of all homeless individuals in New York reside on the street, thanks to this sort of mandate for housing. The city does something really smart, which is all city service calls relating to services for homeless individuals, they map out to try to create these heat maps about where homeless individuals lie. So every time anyone calls 301 about a homeless person needing assistance, needing food, needing medical attention, they sort of map it out. So the darker the dots, the higher the number of calls. And so we can use this to kind of intuit where we think street homeless individuals live. And it sort of fits the patterns of what you might expect having lived in New York. It's sort of mostly Midtown and on down to lower Manhattan. You can see certain features that sort of strike you as being true. So it's a sort of Broadway here cutting over. This dot near us is the 125th Street train station. So a significant number of homeless patients on the street, several thousand in sort of this distribution. If you again sort of map our hospitals on top of that, you can start to make assumptions that will check against our data that for Mount Sinai Hospital and St. Luke's, a significant number of homeless people who live in the shelters, but perhaps fewer street homeless individuals based on where we're located. Mount Sinai West, Mount Sinai Beth Israel, significant numbers of sheltered homeless individuals and street homeless. And so we need to start to sort of adapt our strategies for different hospitals depending on the mix of patients we see, because each different population within the homeless population more broadly presents sort of unique challenges and opportunities. So before I sort of jump into the why piece, I think the question is sort of like why take a population view? Why treat homeless persons as a specific group that we need to target? And so a piece of that is sort of national data. So we have pretty clear data nationally that only about 2/3 of homeless individuals have health insurance, despite many more qualifying. Because of that, they have incredibly fragmented care across numerous health systems and have a real lack of primary care. They have an incredibly high disease burden, both acute and chronic, so high rates of acute trauma and injury, high rates of infectious disease, cellulitis, pneumonia, but high rates of chronic diseases as well. So not just sort of infectious diseases, HIV, Hep C, tuberculosis, but also chronic diseases like hypertension, diabetes, coronary artery disease, all more common in the homeless population and all more difficult to treat. So all that together, not surprisingly, has shown us that across multiple studies in the US and outside, that homelessness is independently associated with an increased risk of premature death. I'll get to all of this, but specific to Sinai, we know that homeless individuals have high rates of ED and hospital utilization and are unlikely to fall up in our ambulatory practices. So that for the most part, we deliver extremely expensive, inefficient, and despite the best efforts of really wonderful doctors, often pretty ineffective medical care to this patient population. A huge proportion of these patients leave against medical advice from the hospital before we complete treatment, and others stay for really prolonged lengths of stay. They have high readmission rates, and then despite all of this, all of the safety net programs we've constructed, they're actually statistically less likely to be enrolled in these programs than our housed peers. And so all this, to me, suggests we need to take a population-level approach to really target these patients and link them with primary care and social work providers who can dive into their individual details, treat them as individual people, and start to understand sort of their struggles. And so one more sort of case to be made on this before I transition to our data is to tell you about two patients of mine. I'll talk about a lot of patients today, and I'll sort of preface this one with the same comment for all the others, which is change initials, age, genders. So these are facsimiles of real people, but to protect their privacy, these aren't their actual details. So Miss L, Mr. K, two patients of mine who have two things in common. One is they lived in the same homeless shelter. The second is they're both recipients of heart transplants. So they lived in the same like 60-person shelter, didn't know each other, and they both had heart transplants, and I was like dying to tell them, like, you need to talk to each other, but I didn't until they figured it out on their own. So both heart transplant recipients who after their transplant became homeless. And I think they're both good illustrations of sort of the damage that housing insecurity can cause in terms of someone's health. And so looking at Miss L, at the time of her transplant, she had extremely well-controlled diabetes, was able to take all of her medications. So this point right here is the point at which she became homeless. This is looking at her A1C, a measure of diabetic control, and her diabetes became incredibly uncontrolled, unable to take medications, unable to take insulin, difficulties taking her immunosuppressants. And so essentially for a 4-year period, she had incredibly uncontrolled disease. And finally being plugged into care, moved into housing, things began to stabilize. But in that 4-year period, she developed incredibly bad allograft vasculopathy, is starting to develop graft failure. It's probably not a retransplant candidate for a number of reasons. And I think we can say for certain that this 4-year period definitely shortened her life. She's likely to pass away in the next several years, whereas at this point she was probably looking at sort of decades more. So huge damage to her. Mr. K, in the period immediately after his transplant, the 18 months, he had 2 admissions. In the 4-year period he was homeless, he had 27 admissions to Mount Sinai, accounting for 240 days in the hospital. So over a 4-year period, he spent 240 days in our beds. He had numerous interruptions in his immunosuppression, numerous infections. He developed cardiorenal syndrome and tacrolimus toxicity, developed a need for dialysis. Still living, still doing well, finally housed in March of 2018, and since then he's been to the hospital once. So his utilization returned back to normal. But this period had sort of irreparable harm to him, to his care, and sort of to his future. And I think both of these to me scream out that this was a moment. This right here was a moment to like do something from a primary care perspective, like ramping up primary care services, specialty service, social work services, and sort of a missed opportunity. And the question is, how do we not miss those opportunities in the future? So, homeless patients at Mount Sinai. So the first question is, how many homeless patients do we care for in the hospital setting? And so there is in the nursing intake questionnaire for all patients admitted to the hospital a question about housing status. And pulling data from Epic on that, we can generate a census of the number of homeless persons in the hospital on any given day at the 4 hospitals that share the same medical record: Mount Sinai Hospital, Mount Sinai Queens, Mount Sinai St. Luke's, and Mount Sinai West. And so this is March of this year. I could have chosen any month, it's always the same. Between 30 to 50 homeless individuals across these 4 hospitals on any given night. One important caveat is we might assume that Beth Israel cares for the largest homeless population. We sort of strongly suspect it does. We have no data. And so the true number is probably more like 50 to 70 on any given night when you think about including the patients from Beth Israel. Looking at specific hospitals, so Mount Sinai West, which we sort of assumed based on its location would care for a large number of homeless patients. Here in gray at the top, sort of like 15 to 17 patients on any given day. Mount Sinai Hospital, Mount Sinai St. Luke's, sort of more in the middle. Mount Sinai Queens, relatively lower. At Mount Sinai Hospital, this sort of light blue graph, around 10 on average at any given night, the vast majority of whom are on the medicine service. And so we care for a huge number of these patients on any given night. What do we know about this population before we start thinking about sort of specifics for patients? So most are admitted through the emergency department, not surprisingly. Most are discharged to the shelter or street when they leave, so we haven't found housing by the time they left, not surprisingly. A shocking 9% leave against medical advice. So that's a rate about 20 times higher than the average population. So they come to the hospital, and then they leave before their recommended course of treatment is over. And then when we look at insurance, not surprisingly, the majority have Medicaid. but 37% are listed as self-pay, meaning they're uninsured. When we go through their charts, about 90% of that self-pay populations would qualify for Medicaid. So most of these patients should qualify for insurance, but we haven't been able to get them to that point. Obviously fragments their care and limits their access to the broader health system. Length of stay, a really important marker for the hospital, and a driver for a lot of the sort of efforts behind this space is what is sort of the length of stay. And so we can calculate expected length of stays based on their DRG, sort of the diagnoses they have. Based on what diagnoses they have on admission, how long would we expect them to stay at the hospital? So looking at Mount Sinai Hospital, based on their diagnosis, we expect the average homeless person to stay 4.3 days. In reality, they stay 9.1 days, so 5 days longer than expected. And I feel like when I talk about length of stay, if I thought those extra 5 days were us like doing like screening mammograms and colonoscopies and like vaccines, I'd say like keep them here, let's do all that stuff. But these days are largely wasted days. You can't apply for housing programs in the hospital. They're at risk of hospital-acquired infections, and we're not necessarily doing anything for them. Across the health system, only sort of marginally better, average length of stay of 7 days versus an expected of 4.4. So a lot of room for improvement. But I think it's worth thinking about this because there's two conflicting things I've said so far, which is 10% leave against medical advice, often in the first 24 hours, yet the length of stay is still significantly longer. And so I think it's helpful to think about what is sort of the housed patient experience at Mount Sinai. And so this is a graph looking on the y-axis at sort of the frequency of a length of stay. So this is 1,000 housed patients discharged from Mount Sinai in March. So on the y-axis, the frequency of that length of stay. On the x-axis, the length of stay of those patients. And you can see that sort of like the average length of stay in the hospital is sort of 4 or 5 days, typical that we know about Mount Sinai. Just of note, this is just for like display purposes. So this actually looks like an incredibly long tail. So I've combined all of the days past 11 into one. So the actual graph looks like a bell curve with a really, really long tail. And you can see about sort of 11 plus days. And so the question is looking at homeless individuals, what does their utilization of the hospital look like? So it looks like this. And so the dark blue is homeless individuals. And you can see the pattern's remarkably different, and different in 2 specific ways that call for 2 different types of interventions. So one is that of these 1,000 homeless patients discharged in the last year, almost 30% left within 1 day of arriving to the hospital. There's almost nothing that you need to be admitted to the hospital for 1 day. So that reflects sort of a failure of care. On the other end, more than 150 stayed for more than 11 days. For example, there was a patient at Mount Sinai West who was very recently discharged with a length of stay of 327 days, so almost an entire year in the hospital. And so these sorts of admissions to the hospital come in a lot of different sort of flavors. So some of it is social admissions, patients who may not have acute medical needs, but we feel are unsafe to return to the shelter or street. Sometimes they end up in the hospital for very short periods, sometimes very long. We have a huge number of medical admissions that are sort of unnecessary, that they have asthma, and if they had access to an inhaler, they wouldn't have needed to come to the hospital. That they have diabetes and they're being admitted with hyperglycemia. If they had access to insulin, they wouldn't need to come to the hospital. And many of those patients have sort of lengths of stay of a single day. The last is sort of necessary medical admissions where we think there's a real need to be in the hospital setting. And those sort of fall into both categories. So the first, they fall into the 1-day category where they leave against our advice very early in the stay. And the other category, they fall into patients who have medical needs that can't be met on the street or a shelter, that they need home oxygen, so they can't return to the shelter. They need wound care or IV antibiotics, they can't go back to the shelter or street. And they're in our hospitals for a very long time, so we try to figure out safe discharge plans. And so that sort of conjures up 2 sort of specific ideas that we've had and tried to do. And so the first is, for this sort of 1-day length of stay, is trying to identify earlier on who is homeless and who needs specific social work services. So you can go from the population to the individual and start targeting their individual needs. The challenge here really is our only data source is the nursing intake on admission, which is a question that goes nowhere. It doesn't flow to any reports, doesn't flow to social work, doesn't notify the teams. It's a complete dead end. So an opportunity that's not being utilized. The second is, given sort of ED length times, a lot of patients are leaving from the ED before they ever get to the floors. And so thinking about how we can move this identification more proximally earlier in their stay. The second is for the people here for a long time, can we create alternatives level of care? So medical respite, an idea of creating a place that's for patients who are too sick to be in the shelter, but not sick enough to be in the hospital. And so sort of target number one is sort of identifying early on. And the question is sort of our current state. Two data points for you. One is sort of provider documentation. Obviously a very small sample size and not very methodologically rigorous, but 100 consecutive homeless patients admitted to the hospital, just reviewing HPIs and discharge summaries. Only 55% of homeless patients who were admitted while homeless and then discharged to a shelter or the street. Only 55% in any note of housing instability or housing status made on their first day of hospitalization. Then somehow it got worse the longer they're in the hospital. We were less likely to mention it on discharge as well. So we're not doing a very good job, I include myself, of asking patients in the hospital about sort of their housing status. The second piece is social work involvement. And when you look at patients seen in the hospital who are homeless, the average time of initial social work note is 2.57 days into the hospital. So this is a statistic that I have made up. This is not in the literature, so I have no idea what the number should be. It seems like it should be less, that we should be engaging our social work colleagues faster for these patients, especially if a third of them are leaving within the first day of hospitalization. 2.57 days seems too slow. So the question is, how can we sort of move this point more proximally? And so we had a lot of buy-in from Beth Israel, specifically looking in their ED. So creating a questionnaire in the ED system at Beth Israel, because Beth Israel, Mount Sinai West, and Mount Sinai St. Luke's share the same ED program. We sort of forced St. Luke's and West along for this ride with us. And so two simple questions asked by the registrar in the ED. So the first is, when they confirm the address for patients, they ask, do you have stable housing? Yes, no, unable. And then if they say they have unstable housing, they ask, where did you sleep last night? And so the question is, what kind of data can this generate for us, having this asked routinely in the ED every single visit? And so this is March 2019, ED at Mount Sinai BI, Mount Sinai St. Luke's, Mount Sinai West. So takeaways, one, the ED is insanely busy. So 21,000 ED visits in March. Wow, that's a lot. Two is a pretty significant number. So 4.3% of ED visits were from persons who are homeless. Keep in mind, despite the huge number of homeless individuals, only about 0.7% of New Yorkers are homeless at any one time. So dramatic overrepresentation. I will also note that 4.3 is an incredibly conservative number because we have this huge pool of patients who either refused to answer or are unable to obtain. And so patients you couldn't obtain information from were people who had acute psychiatric disorders, who were acutely intoxicated, or trauma victims. All three things that are much, much, much more common in the homeless population. So our lowest possible estimate is that about 4% of ED patients, or 4% of ED visits are from patients who are homeless. The true number is potentially even higher than that. Breaking down by specific hospitals, we can learn a little more about sort of the hospitals we're providing care in. And sort of as we expected from geography and the location of the street homeless, Mount Sinai BI and Mount Sinai West care for significant proportions of street homeless individuals. So about 1 in 30 patients coming to the Mount Sinai BI ED live on the street. 6% of all ED visits at Mount Sinai BI in March were in people who are currently homeless. So huge, huge opportunities. But I think the key thing is linking data to action. And so we didn't want to just be the 50th health system to report that we have a lot of homeless patients and they do particularly poorly. And so there's sort of reports being generated at all of these hospitals. And so really incredible work by the social work teams here. So every single day, a report goes out of all people who screen positive for homelessness, going to all of the social work leads for the hospitals, all of the ED social workers, and then all of the floors where these patients are being transferred to. And so this is just an example of the screenshot of the report from BI. So these are all people who were seen on March 21st, all who were either in the shelter or on the street. To the right of his thing, if I actually showed you the full report, is what happened to them, were they admitted, were they discharged, where in the hospital are they currently? So social workers can identify these patients and try to engage with them early on. And our question really is, does this matter? So I am a firm believer that moving social work contact earlier in the hospitalization will improve outcomes, has the potential to reduce leaving against medical advice. Patients leave against medical advice for myriad reasons: distrust of a system, withdrawal from substances, desire to use substances. But a big piece is desire to protect their bed at the shelter and protect their stuff. And social work engaging, calling, coordinating with shelters can help with that problem. And so we really believe that having earlier social work involvement will make a difference. And so we'll see over the next year, comparing Mount Sinai BI, West, and St. Luke's versus Mount Sinai Hospital, where this is not happening. Does this intervention, does identifying these patients early, does it hasten arrival of social work? Does it lessen length of stay? Does it improve enrollment and care coordination? Does it improve engagement in primary care? Our sort of earnest hope is yes, but we'll see. And so I think this is sort of the first step in identifying patients who were homeless. Problem number two, or target number two. So that was thinking about sort of the patients who are here for a very short time, engaging social work while they're still in the hospital. Target number two is patients who are here for extreme lengths of stay, who prove very difficult to discharge from the hospital. So I'll tell you about three of my patients. Again, sort of details changed. So the first, a 62-year-old gentleman, lives in a shared room in Staten Island. He was homeless for many years. He lives in a pretty dilapidated, run-down, single room in Staten Island. Chronic crack cocaine abuse, and sort of in his own words, to generate more money to buy crack cocaine, he invited someone to live with him who has now become an unpaid squatter, and he's afraid to call the police to evict this person. So he's living in a one bedroom with another person who's actively using substances, admitted to one of our hospitals with a heart attack, found to have severe aortic stenosis, 3-vessel CAD, and then on CT found to have a right lower lobe consolidation, potentially concerning for malignancy. So he got an aortic valve replacement and a cabbage, that's sort of indicated. And his disposition plan was to discharge him back to the shared room and connect him with the PCP. Patient number two, 29-year-old gentleman, living on the street or intermittently sort of couch surfing, staying with friends. Known severe aortic insufficiency, planned for aortic valve replacement. So he came in sort of from the street for this pre-procedure catheterization, complicated by a groin hematoma requiring surgery, needed wound care and pain control, couldn't go back to the street, and our plan for him was to keep him in the hospital for 3 weeks while we waited for his previously scheduled valve replacement. Third patient, 57-year-old woman, visiting family in New York, had a previous history of peripartum cardiomyopathy requiring a heart transplant, presented in heart failure, progressed to cardiogenic shock and progressive kidney disease, required a cardiac retransplantation and a renal transplant. Her family support fell through, and ultimately had nowhere to discharge her. So we were at sort of hospital day like 120, and the plan was discharged to a shelter eventually on immunosuppression, a plan that everyone felt equally awful about. And so the question is, what's the role of sort of medical respite? This idea that you can create this place that's somewhere between a hospital and a shelter, where it's for people who are too sick for the shelter but too well to be in the hospital. So looking nationally, California, the state with the largest number of homeless persons, has 15 respite programs with hundreds of respite beds. Massachusetts has about 20,000 homeless patients, has 2 respite programs, one of which has 120 beds. New York, 90,000 homeless individuals, 1 respite program in the entire state. It's 10 beds, it's in the Bronx, it's exclusive to Bronx, Lebanon, and Montefiore. And so our patients had no access to medical respite until very recently, which is a Mount Sinai sort of ICL program. So ICL is the Institute for Community Living, partnership with Mount Sinai, using DSRIP funding to pilot a respite program. So essentially what we did is use district money to rent an apartment in the Bronx. So here's the apartment. There's sort of a shared living space. There's the kitchen. There's one of the bedrooms. So it's a 4-bedroom apartment. So one of the bedroom is used by ICL staff. So there's a staffer there at all times, a social worker, care coordinator, administrator. And the other 3 beds are for patients who need medical respite. And so a really awkward-looking algorithm, but just to help me talk you through sort of the way this works. So using a lot of these reports that we've built, going to social workers, trying to identify in real time patients who are potential candidates for respite, who need ongoing medical services, but don't need to be in the hospital. So coordination with numerous teams. So our goal is to replicate all the services we would need for these patients in this apartment building. So working with the outpatient parenteral antibiotic team to arrange IV antibiotics, partnering with Quorum to do infusions in this respite center, partnering with VNS to do physical therapy, wound care, diabetic education, glycemic monitoring, patient education, anything you could want. So we could sort of mirror everything that could possibly happen at home in this respite program. So once the patient is sort of deemed eligible by the social work team and the medical team, they have sort of a whole assessment that goes to ICL, a conference between the two. Once the patient is accepted, the goal is that Institute for Community Living starts housing applications for these patients before they are discharged. The challenge is you need a lot of stuff, some of which we're very good at getting in the hospital. So you need like full medical assessment, like check, you're on like 10 West, can do that easy. You need a PPD, easy in the hospital. You need psychosocial assessment from social worker, you need that. The hardest piece was they need a comprehensive psychiatric eval for housing. So huge kudos to our colleagues from psychiatry who've done these on the consult liaison services, so doing housing assessments while hospitalized for these patients. Their medical care is all consolidated with me. So everyone who goes to the respite has to or gets to have me as their PCP. So all patients in the respite program are being cared for by one provider. So we have sort of consolidated care. After they leave the respite and are placed in housing, if they end up near Mount Sinai, they can continue to follow with me. If they end up in sort of far-flung boroughs, we'll connect them to primary care with an appropriate skill set in caring for sort of challenging populations. And so these three patients were the first three patients who went to our respite program. So Mr. A is now a month sober. So the longest time he's been sober in the last 40 years. He's been using alcohol or cocaine during that time period. Doing extremely well post-surgery, had a lot of physical therapy while in the respite, doing well from that perspective. Repeat CAT scan actually showed that this consolidation shrank considerably, probably a consequence of his crack cocaine use, not cancer. So things looking really well. Going to be transitioned to a supportive housing program for people with substance use disorder. Second patient came to the respite for 3 weeks instead of staying in the hospital doing nothing. Went back, had an aortic valve replacement, which went extremely well. Connected to a psychiatrist for the first time in like 10 years, being transitioned to a supportive housing program with expertise in psychiatric care. Third patient, the hardest, came to the respite. I'm still working out this one. There's some challenges with her sort of immunosuppression. So continuing to get physical therapy, continuing to get sort of multi-specialty care across the system, connecting to psychiatry, and the ultimate plan is to transition her to supportive housing as well. So potentially 3 patients who left the hospital earlier, got services they needed, and could avert trips to the shelter or the street, moving directly from hospital to supportive housing. And so respite has sort of the potential to sort of transform the way we care for these patients. We have 3 beds, we need like 30 or 300. And so we need to sort of demonstrate the viability of this program. We have exceptional data nationally about respite programs. Now it's just time to prove it here at Mount Sinai. Last piece, and then I want to sort of bring it all together to think about how we practice humanism with challenging, vulnerable populations. Is support for ambulatory services. So if all my wildest dreams come true, we transition the care of all these patients from the hospital to the clinic. Are we ready in the clinic to care for these really challenging populations? Well, we do already. So the CAM building is on 102nd Street, is where most of the practices that accept Medicaid patients go for care to see residents, attendings, fellows. And so we see a ton of homeless individuals in our ambulatory practices because of these 3 shelters. 3 of the largest shelters in the New York City shelter network. About 1,000 patients, single adult males, live in those 3 shelters. To get off Wards Island is like a bus way up into the Bronx and way back down, really hard. Or you can take the footbridge to walk off the island, which is on 102nd Street. So the fastest way to get to any doctor is to come directly to our 102nd Street practices. So if you look at CAM, the ambulatory building on 102nd, there have been about 900 unique homeless individuals seeking ambulatory care in the last year in our practices across sort of all specialties. And so the question is, are we ready to provide care for these patients? And so the third intervention is taking what was already incredibly robust social work services IMA and creating an additional social worker who's housing specific. So this is Rosanna Garcia for the folks who have worked at IMA. So a position for a social worker who's a consultant to other social workers, has a specific housing expertise, having worked in this area prior to her time at Mount Sinai, and then providing primary social work services for patients with chronic homelessness. And so in the last 18 months, had about 90 referrals from either primary providers, from specialists, or from other social workers for care of homeless individuals. So only starting to hit the tip of the iceberg in terms of providing housing-specific social work care for these patients. And to illustrate why I think this is important, I'll tell you about one more patient of mine, Mr. L, 56-year-old guy, street homeless, essentially like lived during the day in the lobby of the CAM building, and then slept on the streets at night. So basically I saw him for a primary care visit like every day for 2 years straight. So the fact that he kept going to the hospital was not a great compliment to me, but we eventually fixed that problem. So he has a history of recurrent lower extremity cellulitis. He has left shoulder pain attributed to a shrapnel injury and hypertension. And so this is not to malign anyone who has cared for this patient. Our job is to be doctors, social workers, administrators. Our job is not to be historians. But when you actually asked him about his military service, because every note says like, go to the VA, VA has great medical programs, go to the VA, VA has great housing programs. He talks a good game, he talks about his VA experiences. But when you actually ask him about his military service, he sort of vacillates between talking about Vietnam and the Iraq War in 2003. And again, why I say our job is not to be historians, but look at his birth date. So Vietnam, the US started withdrawing in 1973. So he would have been 11 when Vietnam ended. The Iraq War was 2003, he would have been in his 40s, right? So right away, you sort of suspect that something is not right here. And so Rosanna, our social worker, called like every military VA contact we could find and finally confirmed he is not a veteran. He has no military service. What he has instead is a really profound psychiatric disorder, but it's gone undiagnosed because he's really quite charismatic and we want to sort of believe his story. And so connecting him to psychiatry was the first step in moving him towards supportive housing. And so in August, he moved into a supportive housing unit for patients with severe chronic mental illness. So he has his own space, much, much happier. His quality of life improved dramatically. And sort of the most amazing thing happened to him. So this is from his chart. So all the red things are ED visits and hospitalization. So it's like every month, multiple times, ED, ED, ED. He went like 4 times in like 7 days. His last ED visit was 7/28/2017. So he has not come back to the ED or the hospital since he was housed. So not a single visit. So he's continued to get primary care, but once we fixed the housing, we fixed everything else. And so housing can be a panacea, but the first step is sort of recognizing the problem and leveraging the resources of the system. And so we have incredible opportunities, we have incredible resources, but it's just pairing those two together. And so I think that segues into sort of the overall strategy and then what we can do as providers in the last sort of 15 minutes. So the things we've done so far, so identifying homelessness early on, linking to social work care coordination, having a medical respite pilot, trying to introduce social workers with housing-specific expertise into ambulatory practices. That's sort of just the tip of what we need to do, and so many other things. So a third don't have health insurance. Like, it's a win-win for the hospital to insure these patients so you can get compensated for the care, and a massive win for the patients to have access to the broader health system. Partnering with community-based organizations, thinking critically about how we link patients from the hospital to primary care, creating primary care competencies for our trainees and our primary care doctors. How do we train them to be better at caring for homeless individuals? So much more to do. And so that also segue to sort of provider level intervention. So 2 things to think about. So one is, of all the problems I have talked about, what can we as providers do to try to solve those on a sort of an individual level? And then what does this skill set look like of a sort of humanistic physician caring for homeless individuals? And so thinking about the problems we'd identified. So delayed recognition of housing status, delayed involvement of social work. So trying to build in smarter medical records to sort of ask earlier on, but ask about housing stability. So there are a million studies looking about like what's the perfect question to ask. And I think the key thing that comes from that is there's no right question, just ask in a way that shows that you care. Like, where are you living? Where do you stay? Where did you sleep last night? Do you have stable housing? It doesn't matter. So housing has such a profound impact on health. It's a key part of knowing what's going on with them, right? So if your patient's in the shelter, and like many of my patients, they are, in an area with 30 people sharing one bathroom, I promise they're not taking their diuretic. I promise they're not going to take their diuretic because they don't have access to a bathroom. So knowing they're homeless impacts the way we should provide care. We know that about 10%, 1 in 10 homeless patients leave the hospital early, so don't be surprised. So anticipate it. Make discharge follow-ups early. Involve social work early to coordinate with the shelter. Try to enroll them in care coordination early. Don't take a punitive approach to them leaving, right? They have a lot of competing priorities. Can be important to make sure that you sort of instill trust and respect with these patients. Long length of stay, consider respite, talk to social work, talk to me. Happy to sort of engage patients in that way. For difficulties with primary care engagement, clarify, assign the PCP, make them follow-up appointments, get contact information. Don't let them escape. Don't let them get away until we have everything we can to sort of try to engage them in the outpatient setting. In this sort of like inpatient, outpatient dichotomized world, there's like one group of people left who see both inpatient and outpatients, and they're all sitting in the back of the room. So I think residents have a really important role to play here in trying to transfer the trust built during a successful inpatient hospitalization to our clinic. So become their PCP, care for these patients. It can be hard to take them on, but really meaningful and worthwhile. The last is trying to enroll them in sort of care coordination programs. And so the last is sort of like, what are these skills? What are the things, if I had 2 minutes, 5 minutes to talk to someone about what I think the skill set is for a primary care doctor providing care for homeless persons? It'd be kind of these 8 things. So one is using motivational interviewing, and not just assessing their readiness for change, but like, what is their motivation for coming? If they're in the clinic, like, why did they come? Like, that's amazing that you came. Like, why are you here? What can I do for you? What else is going on in their life that is that competing priority that you can sort of help them navigate? Emphasizing strengths. It takes remarkable resilience to survive on the street of a shelter. So these patients have remarkable resilience, and tapping into that and emphasizing those strengths can be incredibly powerful. Withholding judgment. So non-adherence or non-engagement can be a rational strategy when you're living in sort of an unbelievable, irrational environment. So they may not be taking their medications for good reasons. They may not come to see the doctor for really good reasons. They're a really stigmatized population with a long history of sort of traumatic experiences. There may be really good reasons why they're not engaging. Having empathy, trying to understand. I don't think we can truly understand what it's like to be homeless, not having sort of been homeless. But trying to understand is crucial. So asking what the shelter is like, what their experience is like, I feel like has opened so many doors for me, just trying to understand their day-to-day. Patients find that so incredibly meaningful when you try to understand their sort of lived experience, even if you can't totally understand it. Trauma-informed care, knowing they've had traumatic experiences with the healthcare system, and being really careful. Ask permission to do anything. Ask permission to do an exam. Ask permission to like draw blood. Ask permission to ask probing questions, knowing that there's a lot of sort of traumatic experiences, and if you push too hard, they may not come back. For all of the homeless patients you see, I can almost guarantee they've seen other doctors elsewhere and not followed up. And so you're not the first person to try to engage them, but hopefully you'll be sort of the successful one. And so for me, I often just even ask, like, who do you get primary care from? And they're like, nobody. I'm like, why not? Like, who did you see before? Like, why didn't you see them again? And then just like, wait, 5 seconds, 10 seconds. And they'll tell you some horrifying story, but it sort of explains everything you're seeing. So asking about their experiences. Calibrating expectations, finding that middle line between not expecting too much of them, but not also excusing low quality care. Having a patient-centered agenda, so figuring out what they want, like why are they here and what can I do to make you feel better? So within reason, my goal in a first visit with a homeless patient is to have them ever come back to see me again. Like A1C like 19, they want to talk about like, that their like left knee hurts a little bit sometimes. Great, let's like talk about that left knee for like an hour. We'll deal with everything else later when they come back for that second visit. The last is celebrating wins, and they may seem small. So people coming back, right? So it's like the end of a day, they're like 3 hours late, they're coming for a second visit. You're like, grind your teeth and say like, I'm really glad you're here. And you're like, I'm really glad, like so impactful, making them feel welcome and celebrating the wins however small, right? Most of these patients have had really negative experiences with doctors who are sort of constantly disappointed in the care they're providing and maybe even disappointed in their patients. And so celebrating those wins really, really important. As the last slide, going back to the very beginning, our definition, I hope you feel like we've talked about all of these things and that you've reflected on your own practice and your own opportunities in your care environment as a clinician, as a teacher, as a leader, ways to sort of better engage with this patient population, provide more appropriate, more population-specific, more patient-centered care. The last and I think maybe the most important point is thinking about our roles as teachers and role models. So we have really clear evidence that as students and residents progress along their training, they become less and less empathetic towards their patients and have worsened attitudes towards sort of vulnerable and underserved populations like the homeless. And so I think there's been a lot of thought about how do we fix that problem. And I think what we've learned is merely exposing trainees to vulnerable and challenging populations is not enough. So passive observation of disparities normalizes those disparities, right? When you just see the disparities and you don't say anything and you don't do anything, it makes that normal. And so the shock, the horror of these patients wears off. And so I think our sort of goal is twofold. So one is find opportunities to let trainees meaningfully engage with underserved, challenging, vulnerable populations. Not just follow along, passively, but have them engage, have them learn about their life experience, have them try to create plans that are sort of patient-specific. Doing that will improve their sort of empathy towards the patient, will improve our attitudes. We have really good evidence of this kind of active engagement with this population improves the way they perceive these patients. The second, and maybe even the most important, is when you have a patient who you feel like is homeless, where you feel stuck with, where you feel like you can't do anything, voice that frustration. Even if you feel like you're totally powerless, commenting on the disparity you see is incredibly powerful. Showing them that you care that this person is not receiving good care, that you care that this person's life is the way it is or we can't do the things we need to. Showing them that you care and are frustrated by it gives them permission to care and helps to build this coalition, this willpower to actually do something about it. So comment on it and get learners to engage with it. That's how we build the collective will to actually do something in a systematic way as a profession to help fix this problem. And so with that, a couple quick acknowledgements, thanks, and then one more gratuitous picture of my daughter. So for the homeless indicator stuff, this is sort of like my fault and Robbie Zimbroff's fault, but all the work was actually done by Aaron Patterson and Linda Hayden to design the IT infrastructure. The ED input thing is like a nightmare to look at, so I have infinite sympathy for them and the ED registrars, but thanks to them. Alicia Tenenbaum from social work. Robbie Zimbroff, soon-to-be graduating student, a soon-to-be internist, who's been really impactful in this and has played a role in sort of all of these projects. And someone that's a student who has really inspired me, and I think why I've loved to work with trainees, is they have new views, new perspectives on old problems, refuse to let old barriers stand in the way, and refuse to accept the status quo. And so someone who's been a real inspiration to me as someone to work with, so Robbie. So thanks to him as well. The respite team, really driven by St. Luke's care transitions teams and the district team with Ed Weege, and then ICL as well, and then from the social work perspective, Rosanna and Kristen. From my sort of DJIM world, Juan, Anya, Mary, huge role in supporting me from the med-ed world. Sal and David Thomas, huge thanks to them for supporting on the way. And thanks to everyone else. From the time I was sitting in the back row furiously writing notes on paper to now I appreciate all the support from folks in the department.
Well, first of all, congratulations on embracing this almost intractable problem and on your lecture style. To switch to the program, have you thought about changing the names and the approach we have and make the street equivalent to, let's say, a nursing home or a hospital where we make rounds and do other things and accept what seems inevitable here, that these people have a deep problem, we know that, and they're going to be in the street, and they were forced into the street by the government, by the way. In the 1960s and 70s, most of these people were in state hospitals, and then the government had to balance its budget, so it closed about 20% of its beds, and they balanced the budget. And now you have this challenge that you're embracing. So my question is, have you thought about looking at it as that's the place they're going to be, and we're going to now add something in the street, not in a hospital, not in a nursing home, but in the street.
Right, an excellent question and a good point. So deinstitutionalization in the 60s was a big push towards why homelessness exploded here and elsewhere. So an excellent point. So we know specifically in New York, the street homeless population is a very small subset who have declined housing for myriad reasons, fear of housing, mental health issues, substance use. It's a really challenging population. And I think you're right. I think the next step from that perspective is there's a lot of street outreach teams who already do this work, but we need to sort of leverage our sort of infrastructure and our IT capacity to actually make that work. For the street homeless, the issue is not inadequate quantity of care, it's poor coordination of care. And so all these patients have gotten, either 0 HIV tests in the last 5 years or like 19 HIV tests. And so figuring out a way we sort of track these patients is the key piece. And so I think what I would want to do if I were sort of the king of Mount Sinai for a day invite them and have a real and meaningful sort of like financial partnership with the teams doing street outreach and provide medical care in addition to their psychiatric care. Most of the street outreach teams are psychiatrically oriented, so combining their psychiatric experience and their social work experience with our medical experience and our sort of IT capacity, I think it actually make changes, because right, that's a very hard population to engage.
Wonderful talk, thank you so much. 2 questions, one about timing, one about money. So the timing of admission sometimes drives this delay that you were talking about. Mm-hmm. So do you have data on what time of day, what day of the week? So is it weekend, is it evening, is it?
Great, excellent point. So no clear trends in terms of day of the week. Like most patients, they tend when they are ED visits come throughout the entire day. For admitted patients, it tends to be like most are admitted kind of at night, and so that's one of the biggest challenges and why we sort of relatively early gave up on the idea of the nursing intake assessment being our point of assessment, because they often came in at night, and even if they got a bed on the floor immediately, the social worker couldn't see them the next day, and so there was too much of a delay. So the ED throughout the day, admissions mostly happening at night, which creates a real challenge in having a sort of lesser social work presence at the time when we sort of most need them there. So it's an excellent point, and creates additional wrinkles in the way we think about matching services to need.
And my other question is about funding.
Yeah.
So if there's a dollar sign attached to the cost saving of having a respite program, is there a, I know likely know the numbers and haven't shown them, but it would behoove all of us to consider the sharing of the cost saving of the program by increasing the capacity of that program.
Great, perfect. And so, we are sort of 6 weeks in, 6 patients into the respite, but the primary thing that will move us from 3 beds to 30 beds is showing financial savings. I think we can. So we have clear data nationally that reduces readmissions, that it decreases length of stay and improves sort of like housing outcomes. And so I think that's the case incumbent on us. So most places have shown annualized cost savings of like multiple millions of dollars per year. I have no reason to doubt that we will be able to show that as well, though maybe not that much with only 3 patients at a time, but over time we can. And so the financial sort of benefit, I think, is the key outcome we need to show. And so far, at least, I think we've averted probably 6 to 7 weeks of hospital time, at least 3 weeks for the valve replacement, at least a week for the patient who had crack cocaine use, and then who knows how long for the heart transplant patient. So I think we can show the cost savings, but we must continue.
Thank you very much, Andy, for a superb talk.